Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. I am Professor Dr. Sarfraz Hussain Sayyed, Head of I Unit 2, Punjab Medical College, Faisalabad Medical University, Faisalabad. We are going to discuss today the orbit and currently the anatomy of the orbit. It is a pair of pyramidal shaped bony structure in the skull with apex posterior and base anterior. It is closed all around the bony walls except the base that is open anteriorly. It houses globe with its associated structures like extraocular muscles, nerves, vessels, lacrimal gland, orbital fat, etc. It is made of seven bones: frontal, sphenoid, zygomatic, maxilla, palatine, lacrimal, ethmoid. It has four walls: roof, lateral, medial, and inferior walls. The roof is made by two bones: lesser wing of sphenoid and orbital plate of frontal bone. The relations of the roof is that above it lies the anterior cranial fossa with frontal lobe of the cerebral cortex and sphenoid sinus. Any defect in the roof results in pulsatile proptosis due to transmission of cerebrospinal fluid pulsations to the orbit. Supratemporal part contains lacrimal fossa, which houses lacrimal gland. Supranasal part contains the trochlea for the tendon of superior oblique. The lateral wall is made by the two bones, greater wing of sphenoid and zygomatic bone. The globe is more prone to injury due to more exposed temporally. So this is the sphenoid bone, the greater wing of sphenoid bone, and this is the zygomatic bone. And this zygomatic bone has a raised tubercle, which is called lateral orbital tubercle of Whitnall. The floor is made by three bones: zygomatic, maxillary, and palatine bone. The, the maxillary bone here, the palatine bone here, and the zygomatic bone here. The relations are that posterior part is thin and made up of and it can be involved in the blowout fracture. Below is the maxillary sinus and may be invaded by the carcinoma of the maxillary sinus, causing the upward displacement of globe. The medial wall is made of four bones: the maxillary bone, the lacrimal bone, the ethmoid bone, and the sphenoid bone. There is a thin membrane like paper-like bone forming part of the medial wall, perforated by numerous foramina for the nerves and for the vessels. The ethmoidal sinusitis may involve this bone and can cause the orbital cellulitis, especially in the children where this lamina papyracea is very thin. The structures which are transmitted from exterior to the orbit or from the cranial cavity to the orbit uh, are through the fissures and foramina. There are two fissures: superior orbital fissure. It is a slit-like opening communicating the cranium and orbit between the greater and lesser wings of sphenoid. Its superior part transmits lacrimal, frontal, and trochlear nerves and the superior ophthalmic vein. Inferior part transmits oculomotor nerve, the abducens, and nasociliary nerves and sympathetic fibers from the cavernous plexus. Inflammation of the superior orbital fissure and orbital apex, called Tolosa-Hunt syndrome, may therefore result in a multitude of signs like ophthalmoplegia and venous outflow obstruction. Inferior orbital fissure lies between the greater wing of sphenoid, palatine, and maxilla, connecting the orbit to the pterygopalatine and infratemporal fossa. It transmits the maxillary, the zygomatic nerves, and the branches of the pterygopalatine ganglion and inferior ophthalmic vein. Here you can see this is the superior orbital fissure, this is the inferior orbital fissure, and this is at the apex is the foramen of the optic canal here. And these are the structures which are transmitted by the superior orbital fissure and the inferior orbital fissure here. Uh, the superior orbital fissure transmits the trochlear nerve, the frontal nerve, the lacrimal nerve, and the ophthalmic vein, superior ophthalmic vein. And the inferior part of that transmits the superior division of the third cranial nerve, the abducens nerve, and the inferior division of the third cranial nerve. And the inferior orbital fissure transmits the inferior orbital vein. This is the annulus of Zinn, also called, because from here this part arise all the four recti muscles and and it surrounds the part of the orbital fissure and also the optic canal through which the optic nerve and the ophthalmic artery is transmitted into the orbit from the cranial cavity. The orbit contains the organ of vision, eyeball, and optic nerve, the supporting structures, the extraocular muscles, lacrimal gland and lacrimal sac, nerves and vessels, and fascia and fat. The clinical features of the orbital disease: the patient may present with eyelid and conjunctival swelling, redness, watering, pain, sometimes on or exacerbated by eye movements, increasing ocular prominence, displacement, or a sunken impression of the eye. There may be double vision and blurring of the vision, sometimes a pulsating sensation or audible bruit can also be uh, seen in these patients. The soft tissue involvement leads to the eyelid and periocular edema, skin discoloration, ptosis, chemosis, which is edema of the conjunctiva, and epibulbar injection may be seen. This may be caused by the thyroid eye disease, the orbital inflammatory diseases, and obstruction to the venous drainage. The proptosis is the most common presentation, and it is an abnormal protrusion of any organ. Exophthalmos refers to the proptosis of the eyeball. The causes of proptosis may be increased orbital contents or less commonly shallow orbits. The evaluation of the orbital disorders are from the history, taking a good history is very important to reach the diagnosis of the orbital disorders. The history established is a probable diagnosis and guides the initial workup and therapy. Such a history should include onset, course, and duration of the symptoms like pain, altered sensation, diplopia, changes in the vision, and signs like erythema, palpable mass, globe displacement. Prior disease like thyroid eye disease or sinus disease, and any therapy taken by the patient. In the history, we should ask about the injury like facial or head trauma. We should ask about the systemic disease like the cancer, and we should ask about the family history like diabetes and other diseases with craniofacial anomalies. We can ask for the old photographs for establishing a timeline of the process. The patient may give history of pain which is caused by inflammatory or infectious lesions, a sudden orbital hemorrhage, malignant tumors of lacrimal glands, metastasis, nasopharyngeal carcinoma in vision to the orbit. We should also ask about the progression, whether it was rapid from days to weeks, it occurs in infectious and inflammatory conditions or hemorrhage, and rapidly growing or metastatic tumors. We should also ask about the history, whether it is slow progression, like in months to years. This occurs in dermoid cyst, benign mixed tumor, neurogenic tumor, cavernous hemangioma, lymphoma, fibrous histiocytoma, fibrous dysplasia, or osteoma. We have to examine the patient specifically for the orbital disease, should give special attention to the visual acuity, pupillary responses, ocular motility, globe position, and ophthalmoscopy. And this can be further aided for diagnostic and imaging studies, which are often required in addition to the basic workup. From inspection, we should see the globe position. That is, the globe displacement is the most common manifestation of orbital abnormality. Or we should see whether the patient has got enophthalmos, which is retro placement of the eye into the orbit. It may be caused by the fracture of the orbital walls or by the fibrosis of orbital varix or secondary to the sclerosing orbital tumors such as metastatic breast carcinoma. The exophthalmos or proptosis, it may be axial or non-axial. Axial mean it remains in the central and it is forward displacement. It occurs in intraconal lesions like cavernous hemangioma, glioma, meningioma, metastasis, and arteriovenous malformations. The non-axial, also called dystopia, when there is some space occupying lesions outside the muscle cone. If it is superiorly displaced, it may be by the maxillary sinus tumors invading the orbital floor and pushing the globe upward. Or if it is inframedial displacement, it results from the orbital dermoid cysts and lacrimal gland tumor. Infratemporal displacement is may be the result of frontoethmoidal mucoceles, abscesses, osteomas, and ethmoid sinus carcinomas. Bilateral proptosis in adults is caused most often by the thyroid eye disease. However, other disorders such as lymphoma, vasculitis, non-specific orbital inflammatory disease, metastatic tumors, carotid cavernous fistula, cavernous sinus thrombosis, and leukemic infiltrates can also produce the lateral proptosis. Unilateral proptosis in adults frequently is caused by the thyroid eye disease, and in children, the bilateral proptosis is caused by the thyroid eye disease, non-specific orbital inflammatory disease, metastatic neuroblastoma, and leukemic infiltrates. We can measure the proptosis by different methods and different equipments. We can measure crudely, clinically, as well as by ophthalmic instruments like transparent rule, Hertel exophthalmometer, nodule exophthalmometer, and lewd exophthalmometer. Now, this is how you can see it clinically. You can see that if we see the patient, ask the patient to extend the neck, and we see through the chin the orbits, you can see this eye is protruded um, with the reference to the cheek of the patient, the cheekbones. Or we can extend the neck and see the patient from by standing behind the patient. We can also see the proptosis with reference to the superior orbital uh, rim. So you can see here there is an increased there is a proptosis in the left eye. Also, we can see the proptosis uh, from the orbital fissure, but this is sometimes misleading. Now, this is an Hertel exophthalmometer, and we rest these 2 points at the lateral orbital margins, and then we look straight um, the eye, the apex of the cornea here, and there is a graduation over there, and we can see through there this on this graduation. This gives us that how much is the proptosis in millimeters of mercury. This is how we can see the apex, and we can see from the pointer that this is that we can measure it uh, with the heart. The other one is nodule. In nodule, we also have the vertical rods on it, and we can also see this is more accurate, especially when there are facial injuries leading to the asymmetry of the orbits. Also, this is a lewd exophthalmometer. This is fastest and easiest, and we rest this at the lateral orbital margin, and we can directly measure the from there. Then there is pseudoproptosis. It is just a simulation of the abnormal prominence of the eye or a true asymmetry that is not a result of the increased orbital contents. The diagnosis should be postponed until a mass lesion has been ruled out. Causes of pseudoproptosis are enlarged globe with myopia like or ophthalmos, contralateral anophthalmos, and asymmetric orbital size, asymmetric palpable fissures causing ipsilateral eyelid retraction, or facial paralysis, or contralateral ptosis. Here you can see this one. This is a thusical eye. You can see this eye is smaller, appears smaller than this one, and then you can see this one has a ptosis in this eye, and you can see this appears as a proptosed eye. Here, this is called a facial nerve palsy here, and also this is a facial nerve palsy there as well. Ocular movements must be um, done on these performed on these patients, and any limitation of the ocular movements should be noted down. It may be a defect of ocular movement due to restriction of the movement. It occurs in thyroid eye disease, uh, in which there is inferior rectus involvement, the most common, and so elevation and depression are both restricted, and there may be hypotropia in primary position. Or rapidly growing tumors may also limit the ocular movements. It may be paralytic due to the ocular motor nerve involvement associated with lesions in the cavernous sinus, orbital fissures, or posterior orbit. We can differentiate the restrictive from the paralytic by the test called force reduction test and saccadic velocities or force generation test. The force reduction test is performed by moving the eye globe in the different positions, and if there is a restriction in the movement, that is called because of the restrictive myopathy. Then we can do a differential intraocular pressure test in which the intraocular pressure is performed in the primary position, and then we ask the patient to look up or down, and then we also perform intraocular pressure. This is called Rayleigh sign, in which if there is a raised intraocular pressure between the primary position and an eccentric position more than 6 millimeters, this test is positive. Then there are other signs, lid signs like lid retraction or lid lag, which occurs in thyroid eye disease. So here you can see this is a primary position. You can see a strabismus, and there is when the patient looks down, it also it is looking down, but when they start look up, there is elevation restriction. Also, there is a restriction of looking towards the left and up and left, and also down and left. And here is restriction of looking down and left in the right eye, here also towards the left gaze and also to the right gaze, and to the here is a it there is a limitation of the up and left gaze. Then we should palpate the orbital rim. Along the orbital rim, we should see whether there is a palpable mass in the supranasal quadrant. It may include the causes of this may include the mucocele, mucopyocele, encapsulocele, neurofibroma, dermoid cyst, rhabdomyosarcoma, or lymphoma. The palpable mass in the supratemporal quadrant may be a prolapsed lacrimal gland or dermoid cyst, or there may be a lacrimal gland tumor or lymphoma or non-specific orbital inflammatory disease. The increased venous pressure may also be performed by asking the patient to have a dependent head posture or to do a Valsalva maneuver, and also we can put a pressure on the jugular vein, and this will increase the venous pressure. And this with this venous pressure increase in the venous, if the proptosis increases, that means that there is the vascular lesion which is causing proptosis. Then we should go look for the pulsations of the eye. It is caused by transmission of vascular pulses through the orbit, mainly an abnormal vascular flow such as carotid cavernous communication fistula, or transmission of normal intracranial pulsations through the defect in the orbital wall, as in the fracture or surgical removal of the roof, or congenital defect in neurofibromatosis. We should also do the auscultation over the globe or at mastoid bone with the bell of the stethoscope, which demonstrate as bruit that can be dampened by gentle pressure on the common carotid artery in the neck in carotid cavernous fistula. This is how we can perform with the bell. We can put the bell on closed eyelid and we can listen to the bruit here. We should also perform the ocular examination on the slit lamp, the conjunctiva for chemosis at the muscle insertions, the cornea for exposure keratopathy, the pupil for reaction like relative afferent pupillary defect. If there is the SOL is causing a compression of the optic nerve, we can have a relative afferent pupillary defect or afferent pupillary defect. The fundus examination is compulsory in all cases of proptosis like optic disc swelling, in compressive optic neuropathy, optic atrophy due to compressive lesions as in thyroid eye disease or orbital or optic nerve tumors or central retinal artery occlusion. We also can see the opticociliary shunt vessels or retinociliary vessel collateral, venous collaterals. The most common tumor associated with shunts is an optic nerve sheath meningioma, but they may also occur with optic nerve glioma, central retinal vein occlusion, idiopathic intracranial hypertension, and glaucoma. We also have to look for the choroidal lobes. Now, this is you can see the conjunctival congestion and chemosis of the conjunctiva due to the decreased venous return through the orbit. Here you can see this is an edema of the optic disc, and then you can see this atrophy. Here there is an optic disc edema. Here you can see the folds of uh, the retina and the choroid, and here you can see the opticociliary shunt vessels over the disc. This you can also see this shunt vessels on the disc here, but they sometimes are look like a hemorrhage. Then we need investigations for the orbital disease to finally diagnose it and then treat it. We can go for a CT scan and MRI. The CT scan is useful for depicting the bony structures and the location and size of the space occupying lesions. It is of particular value in patients with orbital trauma because it can detect small fractures, foreign bodies, blood, herniation of extraocular muscle, and emphysema. It is, however, unable to distinguish different pathological soft tissue masses that are radiologically isodense. Confirmation of an orbital abscess in cellulitis is a relatively common indication. MRI can demonstrate orbital apex lesions and intracranial extension of the orbital tumors and is useful for imaging the orbital inflammatory disease. Serial short T1 inversion recovery, that is called STIR scans, are valuable in assessing inflammatory activity in thyroid eye disease. It should be avoided in ferrometallic foreign bodies, pacemaker, or implants containing ferrometallic materials. Now here you can see this is the medial rectus. Here this is a normal CT scan, and you can see the optic nerve and the medial and the lateral recti and the, the optic canals here. And this is an axial section. This is a coronal section in which you can see the orbit and the nose and the nasal structures. In orbit, you can see the optic nerve, the lateral rectus muscle, the inferior rectus, the medial rectus, the superior oblique, the superior rectus muscles you can see very clearly. Then there is this three-dimensional CT scan which can give you a picture like we see the live skull bones. This is the three-dimensional CT scan of this small child with the craniofacial abnormalities. The secondary studies could be an ultrasonography, which is B scan, A scan, Doppler, ultrasound, and venography, arteriography, CT angiography, and magnetic resonance angiography. Pathological studies can be performed by taking the biopsy and sending it for histopathology. We can do the pathological study on frozen section, flow cytometry for lymphoproliferative lesions, and fine needle aspiration cytology can also be performed. Now here you can see the lesions, the vascular lesions, and here is the angiography of that uh, lesion here. This is also MRA and MRB. The magnetic resonance venography is helpful in diagnosing the venous thrombosis. MRI and magnetic resonance venography are an essential part of the workup of an patient with bilateral optic disc swelling. Lab tests like T4 and thyroid stimulating hormone test in TED, thyroid stimulating immunoglobulins, or TSH receptor antibodies, anti-neutrophil cytoplasmic antibody, serum assay, biopsy of affected tissues classically shows vasculitis, granulomatous inflammation, and tissue necrosis. Although necrotizing vasculitis is not always present in orbital biopsies, Wegener granulomatosis and polyangiitis may also be uh, causing a proptosis. The ACE and lysozymes in sarcoidosis, um, in case of sarcoidosis, may also be required to be tested. The thyroid eye disease is one of the most common diseases which results into the proptosis of the eye. It is also known as thyroid-associated orbitopathy and Graves' ophthalmopathy. It is most common cause of both bilateral and unilateral proptosis in adults. Thyrotoxic uh, is a hyperthyroidism involving excessive secretion of the thyroid hormones. The Graves' disease is the most common form of hyperthyroidism. The pathophysiology is that there is an autoimmune disorder in which IgG antibodies bind to the thyroid stimulating hormone receptors in the thyroid gland and stimulate the secretion of the thyroid hormones. It is more common in females than males and may be associated with other autoimmune disorders. The presentation is often in the fourth or fifth decades. The general symptoms are like weight loss despite a good appetite, increased bowel frequency, sweating, heart heat intolerance, nervousness, irritability, palpitations, and fatigue. And you can see generally the symptoms like hand tremors, difficulty in sleeping, there is hair loss, menstrual problems, there are eye problems, weight loss, irregular heart rate, elevated blood pressure, sometimes nervousness, and feeling hungry, but then again the weight loss with a good intake. The signs of thyroid eye disease are enlargement of the thyroid gland, tremors, palmar erythema, and warm and sweaty skin. Thyroid acropathy is a phenomenon similar to the clubbing of the fingers occurring in 1% pretibial myxedema. 1 to 5% is indurated thickening of the skin of the shins. There is cardiac manifestations like tachycardia and other arrhythmias. Thyroid function tests are initially the TSH level. It may be low or normal, and sometimes when if it is normal, there may be suspected thyroid disease. There a range of additional investigations may be required. The treatment options include carbimazole, propylthiouracil, propranolol, thyroid ablation with radioactive iodine, and partial thyroidectomy. This you can also further read in details from the medical books. Now, this is Palmer erythema. There is a thyroid enlargement, that is goiter. This is pre-mixed edema and goiter, and also there is a clubbing of the hands. The ophthalmopathy or thyroid eye disease, in this the risk factors are major risk factors are smoking and is directly proportional to the number of cigarettes. The female are affected more than the male. Radioactive iodine may worsen the disease, may occur in euthyroid or hypothyroid, and may be presenting manifestations of the thyroid related disease. Pathogenesis of thyroid eye disease, there is an autoimmune reaction. The antibody that reacts against the thyroid gland cells also reacts against the orbital fibroblasts, leading to an inflammatory reaction with inflammatory cell infiltration of extraocular muscles, interstitial tissues, orbital fat, and lacrimal glands associated with increased secretion of glycosaminoglycans and osmotic imbibition of the water. There is increased volume of orbital tissue, especially extraocular muscles. It may be 8 times larger than to the normal volume. This may cause proptosis, secondary rise of intraocular pressure, optic nerve compression, and limitation of ocular movements. Later degeneration of the muscle fibers lead to the fibrosis and restrictive myopathy and diplopia. Clinically, there are two stages. One is called congestive stage, also called inflammatory stage, in which the eye is red and painful, and the fibrotic stage, when the eyes are white with ocular motility defects. These can be categorized as soft tissue involvements, lid retraction, proptosis, optic neuropathy, restrictive myopathy. The signs of Graves' eye disease, there may be no signs. It is called no specs, is the eponym by which you can uh, present it. No signs or symptoms, only signs like lid retraction or lag, no symptoms. Soft tissue involvement causing periocular edema, P for proptosis, more than 22 millimeter on Hertel's test. Extraocular muscle involvement causing diplopia, corneal involvement causing keratitis or exposure keratopathy, and sight loss because of the compression of the optic nerve. The symptoms of the soft tissue involvement, there is grittiness, red eyes, lacrimation, photophobia, puffy lids, and retrobulbar discomfort. Signs of soft tissue are epibulbar hyperemia. It is more at the insertions of the lacrimal gland. This is an insertion of the lateral rectus, where you can see this one, and here you can also see the periorbital edema and the conjunctival congestion and chemosis with sometimes prolapse of the retroorbital fat into the eyelids. The dry eyes are because of the tear insufficiency and instability. The corneal signs are because of the dryness due to the lid retraction and proptosis. There is punctate epithelial erosions. There is superior limbic keratoconjunctivitis, which is sometimes specific to the thyroid eye disease. There may be a superadded infection because of the bacteria causing bacterial keratitis, and later on the corneal thinning and scarring may occur. The lid signs, both the upper and the lower lid retraction, occurs in about 50% of patients of the Graves' disease. The mechanism of lid retraction may be an overaction of the Muller's muscle because of the increased catecholamines in the blood, fibrotic contracture of the inferior rectus and levator palpebris superioris with associated adhesions to the overlying orbital tissues. There may be secondary overaction of the levator palpebris superioris and inferior rectus in response to hypo or hypertropia produced by fibrosis. The symptoms: the patient may have staring or bulging of the eyes, difficulty in closing the eyes, and dry eye symptoms like irritation and decreased watering or lacrimation. There may be a scleral show because of maybe upper and lower lid. Then there is a Daly rimple sign, that retraction of the lid of in primary position. Here you can see the patient is in primary position. Then the left you can see the scleral show because of the lid retraction. This is called Daly rimple sign. Then the patient may have a staring appearance, like you can see there. This is called Cocker's sign or Koch's sign, some people say, especially when the patient is attentive. Then there is von Graffi sign or lid lag. The retarded descent of the upper lid on down gaze is called. Here you can see this one. The patient, when looks down, there is a lid lag on the right side of this patient. This is called von Graffi sign. Then there is a proptosis. There is abnormal protrusion of eyeball in thyroid eye disease. It can be associated with lid retraction, lid lag, abnormal closure of eyelids, and dryness. Can lead to the exposure keratopathy, corneal ulceration, and infection. Here you can see there is a lid retraction and proptosis. Okay, later there is an exposure keratopathy leading to the um, bacterial keratitis. There is a restrictive myopathy in 30 to 50%. They develop ophthalmoplegia. It may be permanent, initially due to the muscle edema, later due to the fibrosis. There may be double vision or discomfort or involvement and movement of the muscle involvement and the movements. There is elevation limitation, abduction limitation, depression, and adduction limitation. All movements are limited either because of the edema or fibrosis. Here you can see this is medial rectus, and you can see this swollen medial rectus here, and this is also a medial rectus and lateral rectus, both swollen. This is an axial view on CT scan, and here you can see that the coronal view of that. They are very uh, thick muscles, and here you can see that they are also compressing the optic nerve as well. Now we have already seen this picture of limitation of the eye movements. The optic neuropathy is a serious complication and may lead to severe visual loss if not adequately and timely treated. It is caused by the compression due to the edema of the recti muscles and soft tissue. The patient may present with loss of central vision, fading of the colors, and intensity of the light may be decreased. There is decreased visual acuity, faded colors, especially the red one. There is diminished brightness sensitivity, which is that if you throw light in both eyes, the one eye may be, if asymmetrically affected, the one eye may have more brightness of that light than the other. The pupil reaction may be sluggish. There may be, on visual field examination, there may be central or seco-central scotoma, which also involves the macula and the optic and the blind spot. The B scan also shows enlargement of the muscles, and the CT scan, MRI, and visual evoked potential can also be performed to see the dysfunction of the optic nerve. We have already seen this slide with enlargement of the muscles and causing compression of the optic. The treatment is to decrease or prevent the risk factors, like stop the smoking. In mild disease, we can use lubricants, topical anti-inflammatory, topical steroids, non-steroidal anti-inflammatory disease, cyclosporin. Head elevation sometimes helps. Eyelid taping for exposure keratopathy. In moderate to severe active disease, the clinical activity score is each of the following features has been assigned 1.3 points or more out of 7 will need treatment. 3 points or more out of 7. Like spontaneous orbital pain, gaze evoked orbital pain. The moderate to severe, the eyelid swelling considered to be due to the active inflammatory phase, like thyroid eye disease, eyelid erythema. Conjunctival redness considered to be due to the active inflammatory phase, chemosis, inflammation of the caruncle or plica. Each is given 1 mark, and if 3 or more marks are there or points are there, then the disease is severe. During subsequent review, a point is allocated for an increase in the proptosis of 2 mm or more, a decrease in the uniocular excursion in any one direction of 8 degree or more, a decrease in the Snellen acuity of one line. The treatment is systemic steroids is the mainstay of the treatment, oral 60 to 80 milligram per day initially, and then it may be tapered off later on. Intravenous methylprednisolone in acute compressive optic neuropathy. Lower the intensity regimens are also given. Orbital steroid injections can also be given. The radiotherapy may also be given. The combined therapy of radiation, azathioprine, low dose steroids may also be given for the treatment of systemic eye disease and the sight-threatening eye disease. If there is optic neuropathy and corneal exposure, the aggressive steroid therapy is required. Methylprednisolone IV sometimes for longer periods. If ineffective or contraindicated, then the orbital wall or apex decompression may be considered. Other latest immunomodulator drugs like monoclonal antibody treatment with rituximab can also be given. Post-inflammatory complications should be treated. The proptosis can be reduced by orbital wall decompression. Here you can see this one is the orbital wall decompression has been performed, in which now the soft tissue has gone into the sinus. It is a medial wall decompression, and so the proptosis has been reduced. There is a bilateral medial wall decompression. The treatment of restrictive myopathy, the indications are diplopia in primary or reading gaze position, No active inflammation and angle deviation has been there, and the angle deviation has been stable for 6 to 12 months. Otherwise, diplopia needs alleviation with prisms or botulinum toxin A. Target is to achieve binocular single vision in primary position and reading gaze. The recessions of inferior rectus and medial rectus with adjustable sutures may also sometimes be required. No resection of the recti muscle should be performed. For lid retraction, if mild, no treatment it resolves spontaneously. Or botulinum toxin A injection to the levator aponeurosis may be given. We can do a molorotomy, recession or disinsertion of the levator aponeurosis, or recession of lower lid retractors with spacer graft.